Okay guys, so today we're going to talk about understanding your wellness screenings. It's a huge topic. I tried to condense it as best I can in 40 minutes, but like I had told the other group, I could essentially talk about colonoscopies for 40 minutes alone. So this is a lot of information. I tried to make it as condensed as possible, but give you all the best information for generally what you would need to know, and also explain why we as doctors do all these things when you come for your wellness exam. And this is, like I said, the big topic, lots of exceptions to the rule. And the reason why I encourage you to continue seeing your primary doctors is because you never know if you might be one of those exceptions to the rule. So, why do we do a wellness screening? Wellness screenings are done as prevention. This is your preventative visit. It's a time to allow the doctor to update your histories, your medication list, your allergies, and complete all the wellness tests that we're actually going to talk about today. And at the end of the day, we want to keep you healthy or get you back on track. So, this is kind of a general outline of what we'll be talking about today. But to start, we're going to start with just kind of general screenings, and that's for hypertension, which is high blood pressure, obesity, substance abuse, and depression. So, high blood pressure. If you've not had your blood pressure checked, I know they're doing it here today. This is what we use. It's a blood pressure cuff. This is a manual cuff. We do this at least every year. That's what we'd like, but we actually do this every time you come to the doctor. We check this for your vitals. Blood pressure actually affects 30% of the population. It's a major risk factor for heart disease, strokes, heart attacks, kidney disease, and it's the evidence that we screen for this that it reduces the risk overall for heart disease. So it's very important. Like I said, we do this every year, every office visit for your vitals. Ideal and perfect is 120/80. Stage 1 hypertension is anything more than 130/80. And anything higher than 140/90 is actually too high, and this is where I always start meds. So lots of factors can come into place for causing you to have a high blood pressure. The perfect way to check your pressure is to actually sit down with your legs uncrossed, be resting, and not have smoked, drank coffee, or done any exercise for 30 minutes before you would actually have your pressure checked. A lot of times in the office I have patients and they're like, oh, well, my pressure at home was fine, but then when I came here it's really high. There is a real thing called white coat hypertension. That's why I didn't wear my white coat today. I didn't want to stress y'all out and cause your pressure to go high. But that is a lot of common reasons why your pressure can be falsely elevated. But if we check this on multiple occasions and it is this number, I start medications. So, and then we screen for obesity, this dreaded scale, but that's what we're screening you for. And we also, to kind of let y'all know, Louisiana's got some bad statistics. We're number 6 in the country for obesity, and as of last year, we're the unhealthiest state in the union. Pretty sad. 35% of our population is actually considered obese. And how do we measure obesity? We do the body mass index, which is actually a calculation based on your height and your weight, and then we put this in. We ideally want to be a BMI of 18.5 to 24. Obese is considered a BMI of greater than 30. So anything like that, we actually break this into 4 different classes of obesity from there. And my goal is to get everybody to this number here to make our Louisiana numbers better. We also screen for substance abuse. So we screen for all of this annually, so it's every year. We screen for tobacco abuse, alcohol abuse, and drug abuse. Why do we screen for tobacco abuse? Because it's the leading cause of preventable death, disease, and disability in the United States. Alcohol abuse affects 7.4% of the population is considered an alcoholic. A normal drink for a female is 1 drink a day, 2 drinks in a male, and anything over 4 drinks at once is considered binge drinking. So I know Mardi Gras is coming up, so I want y'all to be behaved, okay? We also screen for drug abuse, and that's your illicits, marijuana, opiates, most of the illegal drugs. So this is another bad statistic for Louisiana. The average amount of people who are tobacco users in the country is 17.1%, but here in Louisiana, 22.8%. Among high school students, we're also bad here, 12.3 versus 8.8 in the U.S. What's an average drink so y'all know how much is too much? 1 drink is considered a can of beer. A glass of wine and a shot of liquor is considered a mixed drink, and that's how much you're allowed a day. Anything more than that's too much. We screen for depression. Depression affects up to 8% of the country, and we do this by general health questionnaires called the PHQ. It's a different set of questions. It's either 2 questions or 9 questions, and I'll give y'all an example. So this is the PHQ2. It's just a questionnaire where we ask you, over the past 2 weeks, have you felt down, depressed, or hopeless? And you rate that based on 0, meaning not at all, to 3, meaning I feel this pretty much every day. We ask if you lost interest or pleasure in doing your hobbies and things that you like. And if any of these come positive, we actually break it down and ask you the 9 questionnaire. But this is something you will always get asked at your wellness screening, and this is why. Lab work. So, y'all all have had labs done, I'm sure. This is what we do for them. This is a list, and every doctor, the reason I have a lot of asterisks here is because every doctor is going to do a little differently. This is the stuff that I do, and I'm going to explain what I'm checking for in each of these labs mentioned on here. So the first one is a complete metabolic panel. This is a blood test where I'm screening you for your sugar, your glucose, your kidney, your liver function, as well as your electrolytes. This next test is a complete blood count. I'm screening you for anemia, signs of infection, or any of the scary kind of leukemias and things like that. I can see some stuff on your blood counts. I do a urinalysis to see how healthy your kidneys look from the other side, not just in the blood. And this is going to tell me, is there blood in your urine? Do you have signs of infection in the urine? Are we having proteins showing signs of kidney disease in the urine? So that's what we do. And most doctors will always order at least these 3. I always add this too. So a lipid panel is actually your cholesterol panel. This is the test that screens for 4 different types of cholesterols, and it actually tells me your good cholesterol and your bad cholesterol. This is the reason why you have to fast for your blood work. It's because of your lipid panel. Because it can be falsely elevated if you've eaten anything, so this is why we always ask, hey, did you eat anything today? It's because I want an accurate number for this for you. An A1C. So hemoglobin A1C is actually a sugar attached to your blood cell, in a nutshell. Yes, I can check your sugar in this test here, but this is my tricky test I do as a doctor where I can tell actually if you are a diabetic or have some insulin resistance because it gives me the average fasting sugar over the course of 3 months. So you can say, I'm not going to eat cake for the next 3 days because I got my blood work coming up, and this is how I'm going to catch you, okay? Anyway, so that's this test that we do here. And we'll talk about more about diabetes and stuff too today. And then I check your thyroid. So your thyroid's your metabolic hormone. It's a gland that lives here in your neck. And I screen for 2 different labs actually on this because some people can be high or low. And thyroid disease typically tends to affect women more. So I always kind of add this. And vitamins, plus or minus, kind of depending on age. I tend to order vitamin D in all of my females close to menopausal age. And the reason why I do that, vitamin D is very important for our bone health. And if it's very low, it can lead to fatigue. And if it's severely low, it can actually be a risk factor for heart disease. So I always screen for that. And if you're very low, normally we get our vitamin D from the sunshine, and you could actually, if you're really low, go live on the surface of the sun and not replace your vitamin D enough. So that's why we always kind of need to screen for this, and I'll talk about more of that later kind of today. So we screen you on your lifestyle. We want to know how often do you exercise? What kind of diet are you on? Are you a diabetic? Are you on a diabetic diet? Do you have blood pressure? Are you on a low salt diet? So this is kind of times where we can intervene as doctors to say, hey, we recommend you actually work out 30 minutes, 5 days a week. I know that sounds crazy, but if we could just walk for 30 minutes, get our heart rates up, get some cardiovascular activity, we're actually helping ourselves stay healthier for the long haul. And we'll talk about diet based on if you have blood pressure, we would say, hey, you guys need to watch your salt. So this is kind of our screening we would do during the visit. These are some special tests that I also kind of add for patients, and I'll explain these more in detail. So hepatitis C is a virus. It's something to where it's indicated we test you once for this if you were born between the years of 1945 and 1965. The reason we test this is typically called the baby boomer generation. Back in the day when they used to do blood products, like if you required a blood transfusion, they did not screen for hepatitis C like they do now in the blood products. So this is something that's been commonly found, and the good news is there's treatment. So the reason we screen for this at least once you need this lab is because if we catch it, you can get treated and we can help fix the problem. Another test we do is HIV. This is something you can do once. It's optional for the ages between 13 and 64. And both of this tests, the hepatitis C and the HIV, is something we do men and women. This isn't just for females. But to kind of share some scary statistics with you, HIV, we're number 3 in the country. We're number 2 for AIDS cases, and we're number 1 for syphilis. And if you break that down in Louisiana, the per capita, New Orleans is number 2, New Orleans is number 1, Baton Rouge is number 2. So that's why I always kind of offer it, and I tell all my patients that because I think it's something that's very important.
With those statistics that you just gave, is there age involved in that?
There are, well, this is just in general, no age specific. And then if you're younger than 25 years old, we also can do Std screening. Normally they indicate you do gonorrhea, chlamydia, syphilis, but this is something you can actually ask for even if you're older than 25. Normally the OBs typically do this. If you're going to get your pap smear, they'll ask, hey, would you like to do Std screening? And they'll run this too. So the next kind of group is, yes, geriatric group, and I hate to say that 65 actually puts you in that category, even though it seems young to me, but it is the one that we adhere to certain guidelines. We do all the same general screening we do for females, except we add additional things to it. So what we would do is your hearing screen and your visual screen. And in your visual screen, we also add glaucoma screening, which is where they touch your eye with something that detects the pressure of it. So that's something we recommend you do every year. Another test we do is a fall screening. So your doctor will ask you, hey, get up, walk to the door, come back and sit. We're actually timing you and questioning, hey, what is this patient's risk for falling? So that's that test. It's called the get up and go. We also still screen for depression. And memory screening is something I put a star there because it's something plus or minus that we do based on, hey, you know, maybe we brought mom in and the family member's concerned she's starting to lose her memory a little bit. So we'll do an extra memory screening for her, but it's not something we do on everyone. It's just kind of patient specific. And another thing we do is we discuss advanced directives or a living will. This is something I personally spend a little extra time on with my patients because a lot of times people are so confused about this. So I'll kind of give you all the same thing I would tell my patients in the office today. So a living will is not who gets the car, who gets the house. A lot of patients think that that's a will. A living will is what do you want me as a doctor to do for you in the event that you have a health emergency. So let's pretend mom has a heart attack, she's unconscious, the ambulance brings her to the hospital. Does mom want you to do CPR? Does she want to have a breathing tube in her throat to help her breathe? Does she want a feeding tube if she can't eat anymore? This is stuff where you need to have the conversation with your family to determine what are their wishes in the event something scary like this happened to them. Because you don't want to be having this conversation with your siblings in a stressful time, a high emotional time, and you're at the hospital already and you got to make a decision quick. So this is something I talk about with my patients all the time when I do my wellness screening because I even document in the chart what did the patient say they wanted. And the reason I talk about it is because it's something I encourage y'all to talk to your sisters, talk to your parents, talk to everybody. Let them know what it is you want because like I said, don't put this responsibility on the kids. It's your responsibility as a patient to make that decision. Anyway, so that's kind of that part. Yes?
Is there like a statistic on the success rate for like the breathing tube?
That's going to be every patient specific. And it's something too, I don't want y'all to think this is a hard, fast, one-time thing. If you're healthy, you have the conversation with your family. Hey, I want everything done if anything happens to me. Okay, fine, but let's, God forbid, assume, what if we get diagnosed with a terminal cancer? Do you want everything done? You might change your wishes. So it's something, a fluid conversation, it can change, but I just kind of want y'all to know that. And we'll kind of get to, yes.
With that also, don't you need an attorney?
You can, yeah, you can, but the doctors actually can, if you have the conversation with the doctor and we document it, we actually can say the patient wanted this. We're like a secondary person that can call for this, okay? And we'll kind of do questions at the end too if y'all have any more. Next, we screen for osteoporosis. Osteoporosis is a fancy word that means weakening of your bones. It's very common in women, but I wanted to show y'all a picture of what it would look like if we cut your bones in half and looked at them. So this is a healthy bone. You can see kind of the spongy network of it. It's really tight and put together. And think about it, if you have a bridge, the structure, if it's tighter like this, don't you think it's going to hold all the cars better? But then once we get osteoporosis, see how the holes get bigger and these little networks get a lot thinner? So if you put a bunch of cars on the bridge, it's going to crack. So that's what osteoporosis is. By next year, it'll affect 12.3 million people over the age of 50. 21 to 30% of patients who have a hip fracture likely related to osteoporosis will die within a year. And 71% of fractures with patients who have osteoporosis are going to be in us females. When do we start screening? So we start screening at 65 with general screening. That's when we for sure need to do it. Some doctors do this earlier depending on the risk. So go by whatever your doctor says. This is one of those exceptions, but we definitely start them at 65, and you would do them every 2 years. And what it is you sit in a scanner, and I'll show you what it is for what a DEXA scan looks like. That's the name of the test. And we're calculating, based on what the x-ray tells us, a score. And this score is comparing you to the healthy bones of somebody who's 30, because when we're 30 years old, that's the max capacity of what our bone structure will be. So over time, it's going to weaken. So we measure it. This score I'm talking about is called a T-score. Normal is -1 or higher. Osteopenia, which is a precursor for osteoporosis, is a T-score of less than -1 to -2.5. And osteoporosis, where we definitely need to start some medication, is a T-score of -2.5 or lower. This is the scan. It's harmless. You really just lay there. We get an x-ray. That's it. Every 2 years. Harmless test. What can we do to prevent osteoporosis? So weight-bearing exercise. That's walking. Like I said, I want y'all walking 30 minutes a day. The reason why weight-bearing exercise is so important is because we're putting that weight on all of our bones. So we're letting gravity take effect and do some benefit too. If you do a bunch of pool therapy or pool aerobics, you're not putting that weight on your bones because gravity is eliminated in the pool because of the water. So that's why I say walk. You can still do aquatic therapy, but you still need to be doing some kind of weight-bearing exercise. What are some supplements? So most of my patients, if you're close to menopausal age, I put you on this. It's calcium at the dose of 1 gram and vitamin D of 800 units a day. So kind of the general thing I recommend. There's tons of formulations over the counter. I always say Caltrate D, and I'm not plugging for them or anything, but Caltrate D, they're little chewables. They can taste like caramels or chocolate, so I always tell my patients it's like a little sweet treat. And you can get your calcium and vitamin D intake for the day. So you can actually, like I had told y'all, we talked about low vitamin D and the risk factors associated. This is how we prevent that. Now we'll talk about cancer screening. So specifically, I'm doing colon, breast, and cervical cancer because we're a group of females today, and that's the ones that mostly would affect us. But colon cancer. So this, I want to show y'all this because colonoscopies get such a bad rap because you got to drink that nasty fluid. We're going to be on the bathroom all the time. Well, if we don't drink the fluid properly and really clean ourselves out from the inside, this is what as doctors we're looking at on the screen to assess to find these polyps and take them out. So if you don't have a good clean out, we can't see really good. And then that means you got to go do this again. So definitely follow your doctor's directions, drink the medicine, and get it done. But if we ever go in with the colonoscopy and we see these bad guys, which are polyps, we take them out right then and we send them for pathology so we can determine, is this a cancerous type of polyp? Does it mean nothing? But it helps us guide us to how often do we have to keep doing our colonoscopies. Colon cancer is the third most common cause of cancer for both men and women overall. And because of screening and treatments, we've decreased the rate over the past 2 decades significantly. So we normally start at 50 years old. And we can do earlier. It just kind of, this is another one of those exceptions. It's based on, do you have any cancer history in the family for colon cancer? And the American Cancer Society actually recommends we start this at 45. So kind of go based on what your doctor would recommend. The gold standard, like I said, is a colonoscopy. It's good for 10 years. If everything, you did a good clean out, there was no polyps there, this is the test we would want to do every 10 years. Now, if there's polyps, you didn't do a good clean out, or there were, multiple polyps, the intervals are going to change. You might have to do them more often. You can't graduate from this, unfortunately, till I say 85, because the American Cancer Society says 85 needs to be the new cutoff, because we're living longer, we're a healthier country, or population, I should say, than we used to be, and people are living longer ages. So we actually have extended some of the cancer guidelines to keep screening even longer. So this is one I actually recommend as well. Now there are some other options if you're really just, I'm not doing the colonoscopy. These are them, I'm going to talk about them quick. So flexible sigmoidoscopy is something that it's still a camera. We use it like a colonoscopy, but it doesn't look through the whole colon. And I'll show y'all a picture here in a minute. Another test we do is a FIT testing, or an FOBT test. This is, the first one's called a fecal immunohistochemical test, which is a mouthful, but it's a stool test. It's one collection of stool, and that's it. This test is a fecal occult blood test, where we actually have to take 3 individual stool samples to send, and we do these every year. And so those are those. Now some people don't want to do this. You do have to keep your stool in the fridge before you bring it to us. So some people are like, ooh, I don't want to do that. But Cologuard's another one. This is kind of something, some insurances are covering it, some aren't. It again is a stool test, and it's good for 3 years. So you get a little more time cushion versus these. However, you can see I starred them all. If they're positive, you still have to get the colonoscopy. So, and this is kind of insurance specific and every patient specific, but just so you know. This is the test. So this is a colonoscopy, and I want y'all to know when you go in to get the colonoscopy, we've done our clean out, we took all our medicine like we should. It actually takes you longer to drive to the facility, get put to sleep, than to actually have the test done. The test takes at most 30 minutes, and then you're out, that's it. You can go home, eat some real food by the time you're back. So this is the test. So what we do, this is the doctor standing here. This is the actual colonoscope, where it's like he's guiding it with his hand, and this tubing is actually flexible, and it's got the camera on the end with a light, and it's looking at the picture on a TV monitor like that picture I first showed you. So a lot of times if you've had a colonoscopy, they print out the report and it looks like a bunch of screenshots of this. That's what they're looking at when they do it. Now you're asleep, you're not awake for this, just so you know. But when I talked about that sigmoidoscope, this is only going that far. A real colonoscopy goes your whole colon. This is your appendix here, that little tail thing. So we want to know what's going on this whole way, okay? Then we're seeing if there's any polyps. If there's a polyp, we're able to, like I said, take that out and test it right away. So we actually, anything we see, we take it, okay? Like I said, 30 minutes, you're done, that's it. So here's just a doctor joke. I have InterBeauty and I have the video to prove it. So we'll talk about breast cancer. It's the second leading cause of cancer death in North America, and mammography has been the screening test, the best one to reduce our risk of breast cancer. And I know today that they actually have the buses outside if y'all haven't had one. Regular mammograms are the best test to detect cancer early, up to 3 years before you could even feel it by touch. And sadly, another bad statistic for Louisiana, we rate second highest in death rate from breast cancer. So this is kind of based on the American Cancer Society guidelines. A lot of the OBGYNs recommend that you just do this every year. I do it every year, but I wanted to give you all this option as well. We give normally between the ages of 40 to 44. This is kind of optional. It's something based on the doctor and the patient making that decision for them, but you can start at 40. For sure, we're starting at 45, and to the age of 54, we would do these every year. And then if you'd want to kind of space them out, you can do 55 to 74. You get them every 2 years. And normally this is a graduation at the age of 75. However, it's an exception because if you have a risk factor, say you had an abnormal mammogram in the past, or you're a very healthy 75-year-old, like I said, we're living longer, they might push this out even further. This is a picture of a patient getting an actual mammogram. I know they can be very uncomfortable, but as you can see, they place your breast right here, and then these are 2 plates that go and they're actually taking x-rays of the breast. So when they compress the breast, this is what's painful. but you can take some ibuprofen and things like that to help with the pain if you need to. So I wanted to talk to you about some warning signs for breast cancer because we're all girls here today. So if you find a new lump in the breast or under the armpit, thickening or swelling of part of the breast, skin irritation or dimpling, like the skin of an orange, like those tiny pores, if you see anything like that, that's a concern. Redness skin to the nipple area or the breast skin as well. Pulling of the nipple, like if it goes inside versus outside, that's a concern. Nipple discharge, such as a bloody discharge, not breast milk. Any change in the size or the shape or any painful area. That's something I would want y'all to know to tell your doctor. Who's high risk? So this would be your first degree relative, which is your mom, your sister, or your daughter. Or if you've had multiple family members on either side of the family, like say you have a bunch of aunts who had breast cancer, you actually would be a high risk. And then there's also genetic mutations of BRCA1 and BRCA2. I know y'all have started to kind of hear about this. I know at Women's they're starting to do the Myriad testing, which is a great test. They actually make you fill out like a questionnaire paper before you would have this blood test done. And if you are high risk, they run this blood panel. So what this panel is actually testing you for 29 different gene sequences that put you at risk for breast cancer, colon cancer, ovarian cancer, I think pancreatic cancer. And what it is, if anything comes back on that, they obviously go from there as to what they would need to intervene on. However, this test, the reason I like Myriad too, is that you get put into like a bank. So if anything's abnormal and as breast cancer or any cancer developments are discovered with the changing in medicine and technology, they can contact and notify you to say, hey, you actually test positive for this new gene we just discovered. So that's a great thing to know about. Another risk is if you've had radiation to the chest or the breast before the age of 30, if you had like Hodgkin's lymphoma or something like that. So cervical cancer. It's responsible for more than 7% of cancer-related deaths in women worldwide. And the amount of cancers have declined by more than 80%, and that's due to the Pap smear. It's also decreased the incidence and death rate from cervical cancer by half since 1975 because we do the Pap smear. So we start Pap smears at 21, and then when you get to be 30, we add to the Pap smear testing for human papillomavirus, that's HPV. That's been found to actually be a cause for cervical cancer. So they add this to your Pap test whenever you get it. It's not two different swabs, it's the same Pap smear, it's just an extra testing that they do at the lab. Again, can't graduate unless you're 65, no risk, and all normal Paps in the past. And most of the time, OBs do this every year. This is a Pap test if you've been kind of questioning what is it that doctors are looking for. So this is kind of anatomy if we cut you in half. This is your uterus where the babies live until we have them. And this is at the base of the uterus, your cervix, okay? This silver thing is called the speculum. That's our testing instrument that we do to visualize your cervix. And what I'm seeing when I do the Pap smear, this is the view. I'm using the Pap brush to swab for cells at the base, at the opening of the cervix, and that's what I'm using for testing, okay? Now, Pap smears should not be painful, just so y'all know that, okay? And then just talk about special populations. There's a bunch of populations we could talk about, but I decided to kind of focus in on just smokers and diabetics. So if you're a smoker, I want you to quit, okay? Lung cancer is the leading cause of cancer-related death in the U.S. That's why I want you to quit. Most patients are unfortunately already symptomatic by the time they're diagnosed, which means it can be too late. How do we screen for it? This is something insurances are finally kind of coming around to this new guideline. It's been hard to get these covered, but what they recommend is a CAT scan, that's a CT at a low dose of radiation, and a CT scan is essentially a fancy x-ray. And who do we screen? So we do ages of 55 to 80 years old, and this is men and women too, y'all, with a history of heavy smoking. And that 30 pack year, what that equivalates to is that if you've had, let's say you smoke a pack a day for 30 years, you're high risk. If you smoke 2 packs a day for 15 years, you're high risk. And that only applies, we get this test, if you're still smoking like that within 15 years. But let's say you smoked that heavy back in high school and you've quit since 40 years, you don't do this test, okay? This is a smoker's lung. So whenever we were in med school and we did our study of anatomy, we could tell if our patient was a smoker based on their lungs. They look black like this from the tar and the cigarettes. This is a nice, healthy, pretty pink lung. That's what we like. Now, we can't reverse this once we've smoked, so that damage has been done. It's diabetes. So, more than 500,000 people here in Louisiana have it, and more than 100,000 people have it, and they don't even know it yet. Diabetes and pre-diabetes cost us here in Louisiana $5.4 billion. And uncontrolled diabetes can lead to blindness, limb amputation, kidney disease, vascular problems, strokes, heart disease, and even death. What do we do when we screen for this? So let's say we know you have diabetes. I want you coming to the doctor every 3 months. And the reason why, you remember that test I said I used to be tricky to catch you if you're diabetic? That's because I need to test it every 3 months to make sure your therapies that you're on for diabetes is controlling your diabetes. The goal A1C if you're a diabetic is less than 7%, just so y'all know. We recommend you get an eye exam to help prevent the blindness. We recommend you get urine testing to help prevent the kidney disease. We recommend monofilament testing to help kind of guide to know, are you having some nerve damage? And to explain what that is, this is the monofilament test. It's a tiny little fiber. It doesn't hurt when we do this, but we poke on multiple spots throughout the foot to make sure you're not having any nerve damage to the feet. I always, in my office, make y'all take your shoes off so I can see what your feet look like to make sure we don't have a callus, a cut on our foot, an infected toenail or anything like that, because that could lead to maybe we have to have more complications of infection, maybe an amputation. So that's why I want to see what your feet look like at every visit. So a lot of doctors do that. And then vaccines. There's a lot of vaccines out there. It's kind of patient specific depending on who you are, what do you need, but I wanted to talk about the general ones. So the first one, the flu shot. They're recommending we still get the flu even right now. You tend to start it the last week of September through March. And last year the flu shot, or the flu, I should say, was actually so bad where they extended, based on the CDC, to keep giving flu shots through April. We actually saw the flu cases continue through the summer last year. This year, I'm already getting emails from the CDC saying it's another bad flu season. We're in the height of it, so if y'all have not gotten your flu shot, go get your flu shot. So the flu shot, I'm going to kind of talk about the taboo stuff that I always hear my patients always freak out about. So, oh, I got the flu shot and then I got the flu. Okay, not always do we really get the strain on the flu shot. Okay, that happened last year. However, if you get exposed to the flu and say you got your flu shot in October, it's February, you caught the flu. By having gotten the flu shot, we're actually decreasing the symptom severity. So it should not be as bad of a flu had you not gotten the shot. The other thing I hear is, I got the flu shot and then I got the flu. Well, it takes your body 2 weeks after you get the flu shot to build immunity to the shot. So a lot of times that's the culprit as to why you say, well, I got the flu shot right after I got it. It's not because of the shots, because your body didn't have time to develop the immunity to it, and you got exposed to it during that time. The only difference, when you're over 65, we give you a high-dose flu shot. We also have the tetanus or the Tdap shot. The tetanus shot is something we give, like if you step on a rusty nail, we do that. You get that every 10 years. Or we have the Tdap shot, which is mixed with pertussis, which is whooping cough. We give that in all of our pregnant moms or anybody who's going to be exposed to young babies to protect from the whooping cough. We also have the pneumonia shot, which is 2 different shots. If you're immunocompromised, meaning you're diabetic, you have asthma, you're a smoker, you get this shot before the age of 65 once. If you are 65 or older, you have to get the 13, and then a year later we give the pneumonia 23, and we always give the pneumonia 23 in 5-year boosters after that. Shingles, there is 2 shots out there. I'm really promoting the newer one. It's an inactivated virus with 90% of coverage against the shingles. Unfortunately, it's the new hotness, so it's kind of in short change at all the pharmacies right now. But you can, the benefit of it, the old one, the Zostafax, we couldn't give it till you were 60, but now we can give this one at 50. The only downside of it is you get 1 shot, say today, and then you get another one in 2 months. We are recommending that you take it even if you had the old shingle shot because it's got so much better coverage. So this is the end. I just kind of wanted to still stress y'all, keep seeing your doctors. Check in with us, let us know how you're doing. The only way we know how you're doing is if you check in with us at least once a year. We want to intervene if something's wrong, but we want to, at the end of the day, keep you healthy and live a long, healthy life. So, question times or anything.